All right. First, thanks everyone for joining us. This is the beginning of our education series for 2026 for the Metro Seattle Sickle Cell Task Force. Super excited that y'all are here. And we know there are some who could not make it, and that's why we're recording this so that others can see this after this session. We have a lot packed into today. So we're going to go ahead and get started. First, I want to just acknowledge it's a new year. Happy New Year to everyone. So glad that you could come today. Also, we have a couple of announcements, and then we're going to really get started because we have three great speakers today to just give us some new updated education and resource. If you have not visited the website, it has just now been completely updated, thanks to ICE. And our contracted consultants, THT. So we want to encourage everyone, please go visit the website. I think ICE is going to throw it into the chat. And you can check out all the different events. There are also a few resources there that are probably really important. We have some just updated information about various things. So please make sure you go check it out. One of the important pages is the event page. We do try to keep that as updated as we can. So if you're wondering what events are happening, please go visit the site. You should be able to see kind of the upcoming events throughout the year. We also want to highlight Layla is on the call today. She does a wonderful job with our newsletter every month. And if you are not getting the newsletter, please drop your email into the chat and she will make sure that you're on there. She also does all of our communication on our Facebook and Instagram page. So please check us out over there. Layla, if you don't mind, you can drop the links to both Facebook and Instagram. Lastly, or not lastly, we're trying to make sure that you are getting information from us. So we did start a WhatsApp group. If you're not on the WhatsApp group, and that is a better way for you to get information. I think Iceland's going to drop that chat in the link. If you don't see that, please text me and I can get you the WhatsApp link. It's just another way to stay informed about our events. Thanks, Ice. I see you dropping it there. We also have a text group that goes out twice a week, and then we have our newsletters. So just wanting to make sure y'all know these are the ways that you can stay updated on what the task force is up to. We also just love hearing from you. Obviously, we do a lot and put a lot out, but we love also if you just call in because you just want to check in, that is also always welcome. And I think, am I missing anything? Oh, upcoming events. The first one is Wellness Day is coming up. I believe it's January. What date is it?
27th.
January 27th over at the Hub. It is up on the website, so if you want to sign up for any services, please do so. Remember that hair braiding gets taken quite quickly, so if hair braiding is something you need to get done this month, please make sure you sign up quickly. But we'll have all those services available, and we'd love for you to sign up. We are going to be adding a new wellness day kind of once a month, and it is going to be some type of movement class as well as counseling. So we have a new counselor joining the team, and it is a female, and she will be over at the Hub. It'll be probably on a Friday, is what we're thinking, second Fridays of the month, starting in February. So just keep that in mind. You'll see a new event for that, a new flyer information for that coming up. But it's a little bit different than Wellness Aid, not as long, not as many services specifically for movement, making sure that you're moving that body as well as some therapy. So please be ready for that. And the gospel concert is on February 21st. It is a wonderful concert where that's one of our first fundraisers of the year. We know everybody does not go to church, and that is not what this is about. But if you don't mind coming to a church, it is one of our fundraisers, and we would love to welcome you out. February 21st, if you go to the website, you can see all the information in regards to the location. Same location that it's been every year up in Ballard. All right. I think that's enough announcements. I want to really give the floor to Tegan to really talk to us about Sickle Fit. And then after that, we'll take a 5-minute break and then we will have Lenny to come and talk next. All right, Tegan.
All right, thank you so much. Let me go ahead and share our PowerPoint. Can everyone see this fine now?
Yes.
Okay,
Yes.
awesome. Thank you. Hello from North Carolina. It's awesome to see so much good happening out there in Seattle. So thanks for having me back here. Uh, I did chat with this group in, I think, August. So I just kind of wanted to give some updates on what we've been doing over here in North Carolina, and then hopefully what we can kind of help to do over in Seattle in the future. So my name's Tegan. I'm one of the coaches for this program called Sickle Fit. We are a study that's looking at the aging effects in older adults. So I work with Dr. Charity Oyedeji. And I was just going to tell you a little bit about exercise, a little bit about the research with exercise and what we found with our first pilot program of Sickle Fit, and then also what we plan to do in the future and how you might be able to get involved in the future as well. So if you have any questions, please let me know at any point in time. This is our team here. So this is Dr. Yedeji up in the front, as well as the other coach in the center. That's Corey and our other mentor, Dr. Strauss. And there's a ton of people not pictured here that have had a large role in helping develop this. So it took a lot of brains and a lot of hearts and effort to get this program off the ground. But before we get into what we actually did, I'm just going to go over some broad physical activity recommendations. So the NIH recommends about 2.5 hours of moderate to vigorous activity for adults, and they want kids to be active for about 60 minutes a day. But according to the CDC, older adults should strive for moderate physical activity or 75 minutes of vigorous physical activity a week. And they also recommend strength training twice a week as well as some balance training. So that time difference is really just if it's a more intense exercise, usually you have to do a little bit less of it. Whereas if it's lower or moderate, you need to do a little bit more to get all the benefits. However, most Americans do not meet these minimal guidelines. So lack of physical activity is associated with unnecessary increase in health risk. It adds to individual and institutional financial strain, and it also may negatively impact the psychological state of the individual. So it can lead to depression, more anxiety, or things like that. So getting physically active is really important, but as I mentioned, only about a quarter of Americans in the US are meeting the physical guidelines. And as you get older, this number does increase. So 10 to 15% of Americans that are in the older adult range are meeting that standard. And most people are classified as sedentary, spending almost 8 hours a day being sedentary, which a lot of that is out of our control. I mean, let's be honest, with desk jobs and how everything's going with technology, we're just sedentary based on our job a lot of the time. Um, But we do need to take in consideration that exercise guidance may vary depending on other comorbidities or other factors within our life, such as osteoarthritis patients are recommended to do low impact aerobic exercise and low weight bearing exercise. So we don't want people that have bad knees to jump, basically. We want to be a little careful with that, or we want to have slow progressions instead of doing a blanket one size fits all exercise program for everybody of all shapes and sizes. High intensity exercise should be avoided in patients with severe retinopathy. And that's really important for the sickle cell population, as everyone's probably very well aware of. That's very common in sickle cell disease. And of course, if you have acute or chronic injury, if you just break your arm, probably not a good idea to be doing arm exercises right after that. And inactive people should start with lower intensity exercise and gradually increase the duration, probably over multiple weeks. So you don't want to just run into a new fitness program and try and train like Arnold Schwarzenegger or something like that on day one, but kind of building up to it over a period of time. For people with sickle cell disease, they have shown that low to moderate physical activity is really good at increasing work capacity and did not lead to pain crises. So it didn't really affect their inflammatory profile either. So it seemed to be really safe. And even brief high intensity exercise has been seen safe in children with SCD. However, one of the big things we have is there's a gap in knowledge on if any of this is safe or effective in older adults with sickle cell disease. And the main reason that question is important is as people with sickle cell disease age, of course, the damage kind of compounds over time and it can lead to more dysfunction than you would see in a child. So a lifetime of that vaso-occlusive damage might affect the ability for older adults with sickle cell disease to exercise. But we think that people with sickle cell disease can most definitely exercise and they can do it safely and feasibly. But we just want to have a sickle cell disease tailored program So the Sickle Fit pilot study is the one that we actually just finished up as of last year. So we had 30 people enrolled, and this was a virtual exercise program based on a model of GeroFit, which is an exercise program for veterans, and is for people over the age of 40 with sickle cell disease. And we chose this number just because there's a lot of good information research showing that people with sickle cell disease do experience accelerated aging. So someone that's 40 or 50 may be functioning closer to someone that's 70 or 80. And that's why we want to kind of model it after a program that is designed for that age range. That said, it is a very generic, good program. So it's a total body program. We meet Monday, Wednesday, Friday, and we go through exercises, usually with resistance bands or TheraBands and body weight. And we make sure to just follow the standard recommended guidelines by the National Academy of Sports Medicine, in which case we're doing a little bit of cardio, we're doing some balance, we're doing some strength training, and then we're modifying the class based on the needs of the people that are there. So what we did see was out of the 30 people we enrolled in the program, 83% of them were able to attend at least half the classes over the 12-week intervention. So the 17% that weren't able to attend really wanted to actually, but there were issues with time scheduling. Were only able to offer one class at a time. And the people that didn't even make all the attendance actually did see a lot of good benefit, and they just took the education from the class and integrated it in their own life. Uh, and 97% of the people actually said that they really liked the program. We had a 1 to 10 scale, and the majority gave us 10s actually, and most people gave us 8, 9, or 10. And we had no severe life-threatening events occur during the program. There were a couple of vaso-occlusive pain crises, but it did occur at a regular rate. And I think that unfortunately, it's just hard to avoid that in sickle cell disease, particularly in older adults with sickle cell disease. So we did take great concern in that, and we had our medical provider involved frequently. So if we did have an issue, we actually had a healthcare provider basically on camera. If anything were occurring during the exercise, or if anyone had questions um, related to their health, they could just pop on and kind of ask the provider. So when we looked at the exploratory results, we found that a lot of people improved in their gait speed, timed up and go, 6 minute walk distance, and their push up position plank, overhead squat, and leg balance. And most patients reported that they felt better too. So, kind of in line with that 6 minute walk and timed up and go. 88% felt their cardiovascular health improved. Three-fourths felt that their mobility improved. A lot of people said their wellness improved. And then a little over half said their strength improved. The strength was a little bit of a harder one to improve. Since we weren't using any free weights or doing anything in the gym, we were restricted to body weight and resistance band exercises. So we didn't really push like the resistance training too much in this program, to be completely honest. So people did feel stronger. It did affect their mobility, but not like a traditional in the gym strength training program. And there are a couple limitations of the study. The main one being that this study was not powered to make any validated claims. So everything we say is kind of taken with a grain of salt. But what that also means is the results look fairly promising. We showed that we can do this and we can do this safely. So we just need more people in the future to fully power this study, which is where I'll talk about how maybe we can get people involved in the program in the future. And also, we found that the clinically meaningful and frailty thresholds that we have established, they're all estimates and they're based on other comorbidities or populations. So a lot of them are based on people that have a pulmonary arterial hypertension or things like that, or osteoarthritis, and they haven't had any of these been validated in the sickle cell disease population. So in addition to the sickle fit study, Dr. Yedeji and our team are working on the silver study where we're trying to really validate these measures so that we can have a good score and index of people with sickle cell so we can determine someone's robustness level, frailty level, and hopefully have an intervention before it declines too much. And then one of the last things, grip strength and chair stand are really good for indicating frailty. We fully support those tests, but they might have not captured that strength progress. So we're also looking at better tests for determining if someone got stronger from our program. So that's a little bit about what we found. So we found it was safe. We found that we can do it, but there's a lot of work to do in the future. So our next plan and going forward, We're actually starting Sickle Fit 2 right now. It is in institutional review, and that is our random control trial pilot study. We are beginning that at our site where we're going to start implementing the random control trial and make sure that we can do it here. But we also are going to identify about 20 sites across the US, and we're going to do some brainstorming sessions where we're going to interview them and see what we would need to do to implement Sickle Fit at that site. So in the future, we really want to take this across the US, maybe even across to other nations, and find a way to really have an exercise program that caters to people with sickle cell disease that you can access anywhere. So the lesson learned in exercise or lessons learned in advice is really if you can just exercise, try and get that 150 minutes eventually. You don't have to get it immediately. Uh, and don't worry about what you're doing as much. Oops. Because everything works. So it doesn't matter if you're doing the perfect exercise routine. There's a lot of science-based programs or things out there, and maybe some are better than others, but you should really find something that you enjoy. And whatever physical activity is, whether it's dancing, juggling, weight training, aerobics classes, Zumba, they're all going to be about equally beneficial to reducing the mortality risk if you get that 150-minute threshold per week. Um, and then also the slow way is the fast way. So we keep saying like 150 minutes is our goal. We want to get to that amount of time, but we don't need to get there overnight. So you don't need to start the first week getting there. If you know that your physical activity is a little lower, maybe you can start with 10 or 15 minutes a week of walking and then building that up by 10 or 15 minutes per week. And then really slowly adding a bit of time each week until you get to that 150-minute minimum. And that's just a safer way to do it. Really, the big thing that we've learned is if an exercise hurts, probably don't do it. There is probably something that will not hurt and be within your range, and then you can just build that capacity over time. So, particularly at my last talk, I talked a lot about avascular necrosis and how that's a big concern for sickle cell disease people. Uh, Range of motion might be limited. It might be hard to do some squats. It might be hard to do some overhead range of motion, but we find that it is good to take it through the range of motion that's comfortable. And slowly over time, that range of motion hopefully will kind of expand. But just by moving the joints, we are forcing a little bit more blood flow to those joints to hopefully get a little more blood and nutrients to the joints to prevent them degrading anymore. Um, so yeah, that's where we're at. We are looking at sites for Sickle Fit 2, basically. So if Seattle's ever interested, I'll put my contact information in the chat now. And you can reach out to me if you have any questions about our program, if you know anyone that might want to connect with this, or if we do connect with someone and we have this program out there, uh, hopefully you'll see me a little bit more often. We'll get some workouts in together. So that's my main points for the presentation. And if anyone has any questions related to exercise and sickle cell or sickle fit, I would love to help out.
All right, thanks so much, Tegan.
I have a quick question.
Oh, yep,
Is
go
this
for it.
something that you can do, on video from your site here, kind of connect? Or do you have to be physically within the class?
So what we're trying to do right now is it is all virtual. So we are doing it on Zoom and
Oh,
that
okay.
just yeah, so that makes it easier. We also do want to do a kind of a database of the exercises so people can work out on their own time. That 17% that couldn't meet the attendance really wanted some online exercise videos, so we might do that in the future as well. But the big thing is anyone in the program, we would at least want to meet virtually and kind of have an orientation and just kind of like an interview and see where people are starting at. Because at the end of the day, this is really supposed to be a tailored program. So we want to get to know like everyone that's participating one on one.
Mm-hmm.
Yeah.
Okay.
But yeah,
Thank you.
don't have to be in person.
I have another question. I
Mhm.
think I probably joined a little bit late, but I heard you say that the pilot study was for 40 years and above. What about children? Because it's a hassle to get them out.
Right. So they've got some other researchers that have been doing more research into children with sickle cell disease, and it's looking very promising. So one of the things I had cited earlier was that exercise disease or high intensity exercise is even safe in children with sickle cell disease. So that's a space that I think that they have a couple more researchers in, but they just don't have anyone in older adults, which is why we're focusing on that population right now. The dream, though, is we would like to expand this to all ages. If we can make Sickle Fit cater to all ages with people with sickle cell, that would really be the best for us. All that said, is probably going to take a hot minute for that to happen.
So are
Thank you.
participants, are people able to participate on the Zoom uh, class that aren't in the class? Can anybody join in on that?
I wish, not yet.
Okay.
So where we're at right now is we just finished the first pilot study. Uh, this next random control study and the pilot study that we're trying to power a little bit more, we're trying to take it to other sites where then people from other sites, like in Seattle, would be able to enroll in the program by consenting
Mhm.
to the study.
Mhm.
Unfortunately, we can't just make it an open link yet. We need to go through a lot of the process of having the research done to show some clinically meaningful benefit, just so that we can have funding or support for it. So, where we currently are, it is a research study, and people still need to be research participants. We can't just make the link open right yet.
So one of your messages I heard was that if it hurts, don't do it.
Mhm.
It's from years of doing things. We always hear no pain, no gain. But with sickle cell disease and getting people to exercise, I've always encouraged people it's all about longevity. So, let's not get in there like you just said, I'm happy you keep saying that. Just don't worry about doing 50 minutes in one day. But so with people with sickle cell, so you really, when you feel that pain, do not do it. Like say you're doing say you've got a band and you're going overhead with it, but you can't reach overhead. Just reach where you can. Is that a message that we should think of? Go as far as you can and as far out as you can. And I'm just thinking of different things, that people are doing, and just want to keep people safe.
Right. I mean, safety is our main concern because in
Mhm.
a way, I don't care what your range of motion is today. That sounds a little mean, but I'm more concerned with what the range of motion in 6 months or a year is.
Right.
So, and the no pain, no gain one, I actually cannot stand that mentality. We
Yes.
need to get rid of that as soon as possible. Because the
Yeah.
fact of the matter is, the pain can actually make things worse. If you do have a pain, you're going to send some odd signals to your body where you actually start to develop some compensations. So if you're
Mhm.
constantly working through the pain, you actually might be overworking some other muscles and you might develop some other movement pattern compensations that are just harder to correct later down the road. And particularly in the like, and that's what some people in the exercise field might not be thinking about. With avascular necrosis or things like that, you do have literal death of the bone and the shape or head of the shoulder and femur might actually be grinding on the tissue. So there is actually some physical damage that could be caused. So that pain that you're feeling might actually be, picking at the scab or hurting the tissue. So really, we just want to work within the range that we can. And
Mhm.
that is all we need to do. If the range gets better over time, even better. But we usually say if it's a 1 or a 2 on a 10-point scale of pain, maybe you can work within it. There's a little bit of range where like a little bit of pain is acceptable. But my cutoff is if it's a 3 or 4 pain, or if it just feels like incredibly awkward or uncomfortable, we will find another option.
Okay. Thank you.
Mhm. Great question. Yeah, the no pain, no gain. Thanks for bringing that up.
Well, yeah, it's always, and you just, yeah, it's, so you just want to make sure, we have several people that are trying to work out, and, you just want them to be enthusiastic, but just not so enthusiastic that they overdo it, they start slow and yeah, and just build up.
Long-term game.
Yeah.
All right, any other final questions for Tegan?
No, but I appreciate you being with us and guiding us on this because I think it's very important topic.
Thank you. Yeah, I'm looking forward to working with you guys a lot more in the hopefully very near future.
Yeah, super excited about this. Tegan, thanks so much for, and to your team, if you can put it back to them for doing this work. It's really important work. And I hear you saying also for those who are 40 and over not having as much research done. And so it's really great to hear that there is some work being done there. Hopefully we can just keep transferring that down so our young ones are also moving. Um, all right. Well, thank you, Tegan, and everyone for our first session with Sickle Fit. In light of what we just heard, I want to encourage you to take a moment, come out the box, and go move your body for just a second because we've been sitting here for about 30 minutes. So get up, maybe move those joints like he encouraged us, not to the point of pain, but just a minute, just a little bit. We're going to get ready.
Question?
Oh, yes.
Sorry. I was exercising yesterday. And later on in the day, I had some shooting pains. They felt like shocks coming up in my leg, and I've never had them before. Does, with having sickle cell and being over 60, have anything to do with that?
Uh,
Say.
let me go ahead and do a huge disclaimer. I'm definitely not the qualified one to talk about this. But that said, low back pain, 80% of the population has some sort of low back pain or disorder. And sometimes, not saying this is what you have going on, but that shooting pain does sound like sciatica, which is associated with some sort of low back disorder. Uh, are people with sickle cell disease more likely to get low back pain or some sort of sciatica? Probably. I mean, since there's some dysfunction of the hip, usually from avascular necrosis in the lower joints, it may be putting more stress and dysfunction on the back. So what I would say is not quite sure what's going on there, but if you do want to get it checked out, uh, you know, try and document to the best of your ability what the pain feels like, and maybe consider seeing a chiropractor, your primary care provider, and chatting with them about it.
Thank you.
Mm-hmm.
I really plan to.
All right. All right. We're going to take a little 5-minute break and we're going to let Lenny get set up for our next session. Again, Tegan, thank you so much for being with us. And yeah, everyone just go get a drink of water or some fluids and move around for just a minute and we'll see you back in about 4 minutes. All right.
Thank
Thanks,
you.
Roxy. Yeah, have a
Thanks,
great
Tegan.
weekend. Bye.
Thank you.
All right. Lenny, you ready to
Yeah,
all things are ready. Do you have slides to share?
yeah, I do. I can
Sure.
just do a screen share.
Yep.
Um, yeah, and then
Well,
yeah, hopefully that'll go right. There's always some technological thing that could crop up, but what would it be without that?
Right, right. Do you want to practice real quick and just share your screen just so we can make sure it
Sure,
works?
I can share screen. Yeah. Let me grab that. And does that work? Takes a second.
Yep. Bloody
Okay.
noise. Gotcha.
And you just see the slide, right? You don't see anything else.
That's it.
Okay.
Looks
Yeah.
great. You
Okay.
can leave it. You can leave it right. Well, are you going to come on screen and say hello first?
I can do that. Yeah. I
All right.
mean, do I
Not-
show up in a little, it probably
Oh, you
depends on,
do. Yeah, you do. So you can start. You can already screen share.
okay.
And then when we get started, I will, yeah, then they can just see your face. I think.
Okay. Okay, I'm gonna go on mute for the next couple minutes, but you got like a couple more minutes and then we'll start.
Oh, yes, we'll get started. I think I was on mute.
Foxy? Foxy?
Yes, you're still up.
Yeah. listening. Um,
Great.
no, I'm just wondering, will the screen come up?
Yeah, it should come up once we get started.
Okay,
Okay.
thank you.
Mm-hmm. All right, should be coming on back, coming on back.
See nothing.
All right. Let's see. Lenny, will you do me a favor and remove your share for just a second so I can spotlight you? And then that way everyone can see you. 1 second. Ba-da-ba-ba.
I guess I should come off mute too. That would be helpful.
Ah, and hi, I'm so glad that
Hi. Yeah,
this
it's good
all
to
worked out. It's pretty
crazy, right?
fascinating the way Lenny and I got to meet. We'll share that
Right.
story later, but we'll go ahead and get started. You can just introduce yourself and what you do, and then we'll get started on your presentation.
Okay, well, hi, I'm Lenny Carr, and I'm so honored to be here. Thank you for the invitation. I happen to be a vascular sonographer, which means I work in ultrasound, and my specialty is blood flow, and happen to work in transcranial Doppler, or TCD, if you're familiar with that, which is basically blood flow in the brain. So for stroke prevention, and I also work wherever the blood goes. I go. But I'm happy to be here today to talk about one of my favorite things, which is TCD, which is probably familiar with the sickle cell population. So, can everybody hear me okay, or holler or shout out if you can't? I'm going to go ahead and share my screen.
You sound great.
And we good?
Yeah, we're all good.
Okay. All right. So again, I'm just going to give a little bit of the what and the why and the how behind TCD or transcranial Doppler. Let me make sure that that's okay. All right. So what is TCD? It is a non-invasive test that uses ultrasound to evaluate the blood vessels in the brain. And primarily, we look at the arteries and an anatomic structure of the blood vessels called the Circle of Willis. And I'm not really sure why my little video isn't playing. This is a little video that actually shows you the Circle of Willis, which you can kind of see a little bit here, but we'll move on. So anyway, this is an example of the actual Circle of Willis in a cadaver. It is really tiny, so we're looking at these blood vessels that are small and relative to a thumb. It's often been described as about the size of a quarter or a 50-cent piece. So takes a little bit of practice in order to learn how to do this. And sound itself, as you know, doesn't penetrate thick structures when we're talking to each other through a room. It doesn't work very well. So we access these vessels through thin regions of the skull or over the eye or the back of the head where the sound can penetrate. And we call these access points windows. And you can see them here. And we obtain Doppler data or blood flow data about the blood that's going on in your head. And that's, we're looking at both the velocity, which is kind of a substitute for blood flow volume, and we're looking at the quality of the flow as well. And the advantage is that this is a non-invasive test and it's dynamic and live, so we actually see what's happening in real time, and it's cheap and it's safe and it's repeatable. So cheaper than a CT or an MRA. And this is just a picture of what it would look like when we have an imaging uh, a machine that we use, and these are the waveforms that we look at. So you've probably heard about the Doppler shift or Doppler in terms of the weather, or like when an ambulance or a train whistle, the sound of that changes as it travels. So this is basically the Doppler effect is what we're using in order to calculate how fast the blood flow is moving. So the frequency, this is an example, we're not going to go into the formula, of a car honking its horn. And once you put that car in motion, the sound waves that are here, they get decompressed and compressed based on which changes the pitch relative to who's listening and where that person is. So congratulations, you just had like a 30-second physics lesson, and it's not supposed to make sense necessarily, but it changes the pitch, and that's how we're able to calculate how fast the blood is moving. And you know more than you think you do about blood flow because you know about water, and blood behaves similarly. We just call it hemodynamics because heme being blood. But we know that blood flow and water changes the way it moves when there's something in the way. So much like when you're watering using a hose to water your flowers in front of you, that's all fine and dandy. But when you can't reach or you want to spray your pesky brother or sister further away, you put your thumb over part of the opening to reduce the opening, and it changes the velocity and the trajectory of the blood flow. Same thing in your brain. If there's higher flow, we get higher velocities. And if we get a blockage, the velocities change as well. So this is something that we're able to look at on those waveforms that look a lot like this. Okay, so I'm going pretty fast, but how it relates to sickle cell is this landmark study, clinical trial that happened not that long ago. It was in 1998 called the STOP trial, which stands for, well, the Stroke Prevention Trial in Sickle Cell Anemia, but we like to put weird acronyms on clinical trials. And it was published using or with children. It studied with the most severe forms of sickle cell, over 2,000 children from the ages of 2 to 16 with no prior history of stroke. And if you look here, this is the stroke incident, and these are the years. And what happened was there were two arms of the study. So 130 of these children were randomized based on their so they got these TCD exams, and based on their velocities, they were randomized into receiving transfusion or not receiving transfusion. And what they found out was that the kids who received the transfusion had way fewer strokes, and the stroke risk was reduced by over 90%. So they actually stopped the trial early and allowed for everyone to receive those transfusions. It was just that powerful of information. And so that having the transfusion, of course, adds normal red blood cells. It reduces sickling, improves oxygen delivery, and slows down the velocities in the brain. So that's really what we're looking at, and it lowers the stroke risk. So this study was incredibly important in establishing guidelines for us to use when we do these exams. So you may hear different types of criteria when you come in for your TCD exam and we set that transducer on your head. You might hear a little bit more about, oh, we had a normal study or a conditional study or elevated velocities, and then that's what actually chooses a pathway of what happens next. So why do these velocities matter? Well, they're mainly caused by we call this chronic anemia-induced and vasculopathy-related changes in the cerebral circulation. Well, it's basically just saying that when you have chronic anemia, it leads to increased blood flow to compensate because we don't have good blood flow. So our bodies try to make up for that. And then, these patients have lower hemoglobin and reduced oxygen capacity, carrying oxygen carrying capacity, can't speak. And then there's damage and blockage to these blood vessels from that high flow or from the sickled blood vessels, right? They become stickier and they can create blockages. So we get inflammation or vessel wall injury, and that's called stenosis. And so when we see a stenosis, we also get higher velocities. So we're really cued into that. And it's a very simple test that we can do just monitoring these blood vessels in your brain and evaluating the flow. So the reasons for it can be what we call high blood flow or hyperdynamic flow. Chronic anemia produces this high flow state, and that can increase or translates into high velocities. And anemia also reduces the blood flow stickiness in the blood itself. So anemia can actually lower the blood viscosity, and that can cause blood to travel faster. So all of these reasons, there's also other reasons that blood flow can elevate. These are reasons why it helps indicate whether or not there's a higher risk for stroke. And it's pretty consistent. So again, you hear these guidelines if you've had someone or you yourself have had a TCD exam. You might hear normal based on these velocities, that we see conditional, meaning instead of repeating this test yearly, we might repeat it within 3 months. We might consider an MRA or an MRI. If they're elevated, now we're having different conversations and you're repeating them maybe much more frequently, like within a month. The patient might go on to further testing, have neuropsych referrals, sort of really evaluating a little more closely of what else might be going on and whether or not it makes sense for transfusions to start. So, and it's also important to note these are not the peak velocities that we're looking at. These are actually mean velocities, so an average during the exam. And it's not a perfect test by any stretch, but has a profound it's really been helpful in helping figure out how to direct patient care. So, deep breath. The considerations and limitations that are helpful for you all to know is a couple of things. There's two different types of exams that offer TCD. One you can see here doesn't produce an ultrasound image, and the other one, this is one you can see an image up here, produces an image inside the brain. And so the one without imaging, called non-imaging or blind, just produces the waveform. The other one produces an image along with the waveform, and that's often referred to as imaging TCD or TCDI. Now, there's differences between the two. And the main thing is that the criteria that we use is based off of studies that used blind or non-imaging TCD. And imaging TCD, while really nice and useful and produces a pretty picture, tends to have lower velocities. And if we're using those velocities, but the non-imaging criteria, we might miss some indications in how we classify our patients. So it's really important to know if you have a study with an imaging system that the criteria might need to be adjusted a little bit. And there's not very many studies that are really validating the difference. But the reason that we use imaging is that, and actually a couple of reasons, it might just be that the lab has that type of ultrasound system because they use it for a number of types of studies in looking at different parts of the body. Whereas the blind or non-imaging machine, that's devoted equipment that's just for looking at vessels or listening to blood flow in the brain. So, and a lot of people would say that as we train people, this is a very specialized exam that some people argue it's easier to learn with imaging versus non-imaging. Don't necessarily agree with that, but those are some important considerations if you have someone going into that exam to just sort of think about. And it's a good question to bring up. The other thing is education. I think I mentioned this is a subspecialty. So we have our training. If I'm a sonographer, I'm trained in blood vessels, or I'm trained in the heart, or I'm trained in other structures. But this education is really specialized. So it does take a little bit of extra training, and we're working on certifications for that. And then also research. So this STOP trial was phenomenal in that it studied a pediatric population. But what does it mean when you're 17, 18, 19? When are you classified as an adult? And we also know our blood flow changes and our velocity changes as we age. So normal range of velocities are different for adults than they are for kids. So how do we adjust for that? So that is where research can come in, and same thing with gender. Like, now, how do we know which populations we're looking at, and does that have an effect? And again, how often should we be looking at these things? And so any other factor that's going to affect blood flow. So there's a lot of room for research, and it's really important that we get this data and that we can find out more and learn more. And then there's just inherent limitations within the TCD technology itself. It's very user dependent. I can make any one of you look normal or abnormal if I don't know what I'm doing. And then there's also limitations just to sound in general and how it behaves, and then anything that affects blood flow. So it's not to like throw the baby out with the bathwater. It's still incredibly useful, but these are just sort of some things to think about. It's not a perfect test, as most aren't. And I guess the key takeaways here, if you're wanting to know really why it's important, is that it is an important test in stroke prevention and care, and it helps doctors decide, is a transfusion needed or should we consider the timing of it? Now, that's not the only conversation you're going to have. Communication, the second point, is really key. Discussing options with your provider and other information and what is right for you. And then again, the limitations of the testing, like who did the test, what type of test, and what other factors around you that might be going on in terms, like for example, if you just recently had a transfusion, those would lower your blood velocities, and that we would need to know that. So the more we can learn about the test, the better the test can become. And then speaking of education, I just want to sort of throw a little bit out there that this is also a great career option. So the medical sonographer, you usually go to school for one of three different specialties. You can go to become a general sonographer, which think liver, gallbladder, or kidney. You might go for echocardiography, and we call that echo for short, which is cardiac care. Or you might do what I do, which is vascular, so all of the blood vessels. And then within each of those, there are, of course, subspecialties, right? We have people that do OB or high risk pregnancies. We have pediatric, adult, and fetal cardiac evaluations that we really want to specialize in understanding disease processes. And then for us, TCD, we have venous specialists when we talk about veins, and then peripheral. So if you're limb loss patients that might have issues either in their carotids or their legs or their arms, we're dealing with that as well. And again, TCD can often be taught as a subspecialty for either any of these main specialties that you start off in. So, but again, it does require advanced education and it is pretty specialized. But for the most part, a sonographer, it's a 2 to 4 year program. You can get them. I used to teach at Bellevue College. It's a great program there. But you want to go to an accredited program. It is high job security right now. There's advertisements daily for people there that are filling the need, and bonus if you want to go move across the country, they're offering hiring bonuses. It's great pay and benefits, and again, there is a current nationwide shortage. So I am happy to talk about my personal experience and geek out with you about hemodynamics, TCD, or the career in general. It's definitely brought me a lot of satisfaction. It's been challenging, stimulating, a source of job security. And then I'm also happy to discuss the good, the bad, and the everything in between because I feel like I've learned patient care, I've learned understanding more about our bodies, our health, the healthcare system. And it's certainly brought me wonderful opportunities in terms of teaching, research, consulting, and travel to cool places. This is actually me in Ethiopia. I had the opportunity to go teach some physicians abroad. They often don't have sonographers, so physicians are the ones that have to do these tests, and so it's often a privilege and just such an amazing learning opportunity to be able to go abroad and offer a shared knowledge. So that is a quick slam of everything that I can bring you, and there's always more. I just want to say thank you, but I actually want to move into if there's any questions. I want to answer those, but I feel like I have questions for you. I feel like I can learn just as much from you about what TCD means in this population and what it like. What do you wish those of us who do the exam knew about your experience or how it's framed? Those, I feel like that is something that I can bring back to my community, and it's really going to help. So I'm done with my talk. I'll be quiet for a second, but please chime in if you have anything to offer up. And I'll stop share. Let me do that. Crickets.
I wanted to say thank you. Can you hear me?
Yeah, I can hear you. Thank you.
Okay. Because I just got a blood transfusion a couple of days ago.
Uh-huh.
And I was questioning it because I felt like, I don't want to keep getting blood transfusions, and I don't get the energy most people say that they get from them. So,
Mm.
um, but the main thing is just that to hear that it is helping with some, I know it's helping, um, but to know that it's a good thing sometimes to have them. But I'm
Yeah.
on a
Have
week.
you had one?
Yeah, I just
TCD?
had one a couple of days ago.
The transcranial Doppler exam or the
Oh
transfusion?
no, no,
Okay.
just transfusion.
Yeah.
I'd like to see if they'll do that. I don't know if they do that. The testing.
Oh, the testing? Yeah, I don't know. I would have to, it probably depends on where you are. And again, I should have qualified. I am not a physician. I am a sonographer, so I help
Yeah.
give information, but in terms of the availability and when is the right time to order, that would have to be more of a physician question than something for me. But I mean, there's so much potential with this very simple technology in many other realms, not even just with sickle cell, but because blood flow changes and it can really indicate different things that are either about to happen or did happen just by looking at it.
Okay.
Just to add
I
on
think,
to what Denise was talking about, I recall when my daughter had a blood transfusion. Before we went for her TCD, we were told to hold off. I think it had to be 3 months after you have received the
Yes.
transfusion before you can actually go in and do the TCD because you're going to get, I think, like you explained, it changes the velocity of the blood flow.
Yeah.
So it was, I think, we had to wait 3 months uh, after before we could do her scheduled TCD.
Yeah, and you're absolutely right that basically once you receive a transfusion, they've basically in many ways sort of normalized the blood. So if we were to test you, you might get a false normal base or a false negative. So we want to see what's happening in there any trends further out because it will affect what we see because that's all we can see. So that's the thing that is another limitation is we really anything that's going to affect the blood flow would affect the results that we get. So it makes sense that there's a gap in time. Or if you happen to have a TCD scheduled, it's important for us to know when your last transfusion was. And again, gathering that research is or that information is really helpful for us or any person who wants to go into research in terms of, oh, maybe it doesn't need to be 3 months, maybe it's 6 weeks, maybe it's 2 months, so those are things that are still really debatable, right? And those are things we can learn from.
well,
I
I
had
think
one more
that,
question.
well,
Oops.
go ahead.
I had one more question. I know I wanted to make sure I understood. You said that when we're receiving those TCD tests, that it's nice to know which kind you're getting, whether it's an imaging one or I think the regular one. What would be the right questions to ask, the people who are doing them?
Great question. That's a great question. And so you'll know if it's imaging because it'll look like a standard ultrasound machine, and you'll actually see an image, like I showed, of color around your brain. Or if you usually should see something like that gray matter up there that's representing the inside of your skull. And if not, it's a much smaller system, and all you see are some red, potentially red and blue stripes and some waveforms going by. So that's how you can tell. And really, you can just politely ask, especially it's more if you're close to a cutoff point in terms of how you're categorized as normal, conditional, or elevated. But basically, it would be what criteria are you using in terms of it, there's a common knowledge now to downgrade imaging velocities. So it's good to know, like, did they do that? So I know that, okay, well, if I'm close to it, are you downgrading the criteria from the stop trial, basically? And it's in it, but it's a downgrade. It's not perfect. There's not enough studies out there. Haha, I got Bender in here who's going to talk about it. This is what you should say to your doctor or not. But we need more research. We really do, because it needs to be better validated for an imaging study. Because I think as we need more specialists to do this, we need better criteria. And it's easier to teach if you know what you're looking at and what you're looking for. I want to hear what you have to say.
Um, it is a tough situation, but a lot of people are looking at it. Both techniques work really well as long as the people are like Lenny and know what they're doing. And so you have to interpret them a little differently depending on which technique it is. So there's a
Yes.
big push across the country to make sure each institution and the radiologists and the sonographers know that you use different numbers depending on the test. So years ago, we worked with the people at Children's to come up with a grid that if you use this kind of machine, this is what you use. If you use that machine, this is what you should use. So don't feel you're getting a better test if you have imaging or non-imaging. The
Yeah.
important thing is that the people know what they're doing. And at Children's, they've sorted that out.
Thank you for that clarification. Absolutely. And it's more probably on the interpreting physician or the physician side of things that they really need to know what criteria is being used. So are you saying the question to ask is if the sonar, how good are you? Rather than what criteria you're using. They really do adjust for it. They should adjust for it naturally. And certainly at Seattle Children's, they are excellent there.
Well, the other part of this is I think that we should be asking our doctors about this test,
Mhm.
whether we should have a yearly or on a reoccurring pattern so that we can see increases, decreases, or changes so that those can be treated and understood. I think that a lot of people don't have these tests, and I think that's because that we're not asking for them, and that the docs may not think it's important. But as you have raised, it is important to see um, how the blood flow changes over time.
Yeah, and I also think that the reverse is true. If you have a physician recommending it, absolutely. It is relatively cheap, it's relatively easy, and it can bring a lot of good and useful information. And the more we have people complying with it, the more information we have to move forward. So if they are asking for it, absolutely, there's no harm to anybody doing it. It's ultrasound, right? So but yes, the reverse is true. We could use more studies in adults. We could, like how much does it, what are the cutoff points? We know when a high velocity is high. We know extremes, right? But how could we actually come up with more information? Just like as you said, how important is the frequency? But if they are recommending it, I recommend you repeat it in 1 month or 3 months. Absolutely. That will do nothing but help.
The other thing is too, I believe that um, people need to, while the test is going on or before that, understand what it's for. I think that people are, they um, get this exam or they're ordered to have these exams, but they're not exactly sure what they're for. And I
Mhm.
think that the ultrasonographer should be able to convey that to them so they have a better idea instead of just going there and, okay, I'm here. Okay. Well,
You're absolutely right. I think that even when we're scheduling it, if people are reaching out to schedule it, that's an excellent opportunity to explain the why. And then when the patient comes in, of really why it's important. So that's really good feedback for us to hear because we get so hyper focused on what we're doing and we're just ready to perform a test. And that's a really easy step to miss even before someone shows up. And I do want to highlight what Bender put in the chat that the screening risk for stroke, like we said, is really in the pediatric population, so under 17. And only with certain, so SS, so only with that population. So it's not necessarily a test that everyone needs. If I had a grant that could cover everything, I would want to study everyone at all ages, but we don't, that's the piece is like there's still questions out there, but right now it's really for specific population, pediatric and specific types. So thank you for pointing that out.
All right. Wow. Thanks so much, Lenny.
Oh, thank you. Thank you very much. I
Yeah.
really appreciate the opportunity here.
Yes, this was so great, so great. And I feel like you gave us a lot of education. Thank you everyone for asking the questions. And yeah, just again, I'm a little bit in awe because Lenny and I were met in a retreat space, and then she told me what she does, and I was just like, bam, let's make this happen. And really worked really hard, I mean, quickly to make this happen. So thank you. And then I'm making sure, did you feel like you got the questions that you wanted answered? And if not, we would welcome you to like maybe one of our Wednesday night community group times. If you have more specific questions you'd like to ask, we can like send them out early so people can think about them.
Yeah, I mean, I would just invite, I mean, we need to be educated too, right? And so, what is the experience? What does it mean to you? I mean, because it's only going to help if we can all figure out it, like clarify. And I'm love learning more about what my patients experience or what the impression might be, because we can't solve for that if we don't know. So it really, if anyone ever wants to reach out to me, please do. And yeah, and I will say the only reason it got started was you were wearing your sickle cell sweatshirt, right? And I saw that and I was like, wait, what was that? Yeah. Yeah. Thank you very much.
Yes, awesome. Thank you so much. All right, friends, we are going to take a little bit of a break again, just so you can get a little bit more movement in, grab some water, do whatever you need to do. And then we have Dr. Adesina here, Dr. Bimby. Hey, you made it on. And she's going to really be having a discussion around sickle cell and the bones. So I want you guys, like, if we could just take maybe just like 4 minutes again, go do whatever you need to do, and we'll be right back on at 10 after, and we'll get started on our final session. All right. Bimby, do you want to share
Yeah,
anything?
let me go ahead and share,
All right. You
see,
want to
make
just
sure it works
practice?
just fine. Yeah.
Sounds great.
Yes,
Hi.
so hi, good to see you. Happy New
You
Year.
too. Happy New Year.
Sorry, I was like, why did my computer decide to reboot? So I
It
was
always,
logging
it
on.
always happens, you know?
I know. Alrighty, let's see. I'm sharing the right one, I hope. Um, slideshow beginning. Okay, does it show the full thing or?
Sure does. Yep.
Okay, awesome.
Yeah.
So I'm just gonna run through just to make sure. I
Okay.
only have about 15-20 minutes, correct?
Yeah.
Okay, all right. We'll keep it sweet, short and sweet. Yeah, okay,
All right.
that's good.
All right. If you want to stop share for just a second, I'm going to make sure I spotlight you so then people can see you and your screen.
Sounds good.
All right. And then in a minute, we got 2 minutes, then
Okay.
we'll start up. Are you doing new work in this? Are you
Mhm.
continual work?
I'm continuing my work.
Yeah.
We just opened, I think our third or fourth study
Wow.
on sort of on this avenue of bone health, and we are actually going to do instead of imaging only, we're also going to do an intervention. So similar to what Judah got, we're going to do like the oral form of it over a 6-month period, and
Wow.
then measure um, all the usual things like the labs, the pain markers. And then we're also doing this really cool imaging thing that I'm going to slightly just present briefly to the audience,
Oh,
how we can measure in real time how blood is flowing in and out of the bone. And our
wow.
hope is that as these medications improve um, bone health, we think one of the ways that it does that and reduces pain is it improves blood flow to the area where the bone had previously not had enough blood flow. And so, yeah, that's our third, is it fourth? I'm losing track, but that's like our third or fourth study in this space that we're working on.
Super exciting.
Yeah, it's really
Super
cool.
exciting.
How
Yeah.
is Judah? He's good?
He's doing all right.
Good,
Yeah,
good.
he's
I'm
doing all
glad.
right.
I'm
Yeah,
glad.
yeah, for sure. He's living on his own and
Oh, good.
yeah, yeah.
Oh, that's awesome. That's
Yeah,
awesome.
doing really well.
Can I
I'm
All
gonna
right.
make sure I
we
mute
should
my
we get
phone.
started?
All right. Nope, we're about to get started.
Oh, all right.
All right. Hello, everyone. This is our final session. I'm super excited. Y'all know this is kind of personal for me and Judah's story, but really excited to have Dr. Bimbi Adesina here and really going to talk through the work of researching sickle cell and the bones. I don't want to hold you guys any longer. I just want us to get into this. So I'm going to pass it on to you, love.
Okay. Hi, good afternoon, everyone. My name is Bimpe Adesina. I think I recognize some names in the audience. I hope this thing is on. I think I recognize some names on the screen, but for those who don't know me, I previously worked at UW. For about 3.5 years from 2017 to 2020. And then now I am at the University of California, Davis. And my area of expertise is adults with sickle cell disease. And my clinical and research interest is bone disease and bone health and how it associates with pain in people with sickle cell. So that's what I'm going to be talking to you guys about today. Go ahead and share my screen. Um, and then I'll just go through it. But if anybody has questions, please feel free to either drop it in the chat and maybe Foxy can get my attention or just, speak up and I can pause and answer questions in real time. So once again, I'm just going to be talking about sickle cell disease and bone health, specifically focusing on low bone density or low bone mass in people with sickle cell and how that associates or its impact on pain and avascular necrosis or AVN. I also wanted to talk about a study that we did where we were interested in measuring how blood flows to the bones because we think that poor blood flow into the bone is what's causing some of these complications that we see, and then talk about potential actual treatment options to optimize the bone and reduce pain in people with sickle cell disease. So why, when we start to think about how sickle cell affects bone mass or bone growth over time, I just wanted to share this. This is a normal, this is like a skeletal development in somebody who doesn't have any chronic illness. And so we are all, I hope you can see my pointer, I think. We're all accruing bone. Like in that first 2 decades of our lives, we're accruing bone. And then somewhere like in our mid-20s or so, we kind of hit our peak bone mass where, we kind of plateau and then we start to sort of decline over time. Now, in women, who are represented here in like the solid line, they the decline in bone mass is more rapid after menopause, and we think that's all related to hormonal changes. In men, that decline is much more gradual unless they have some sort of chronic illness. And then in people with sickle cell disease, people with juvenile arthritis, other chronic diseases that start in childhood, they actually are at a starting off at a deficit. So they actually, because of their chronic illness and the stressors on their body, they're not able to accrue the same amount of bone as, let's say, people that don't have any chronic illnesses. So if you are already starting off at a low point when you hit your plateau, you don't have very far to go before you get into that osteoporotic or increased bone fragility uh, territory. So in this scenario, it's not surprising why low bone mass or low bone density is very common in people with sickle cell disease. And that's one of the things that my work is trying to highlight, the critical importance of bone health and how that can really mitigate pain that a lot of adults, actually even adolescents, struggle with. So my colleagues and I had previously looked at a group of about 300 children and adolescents with sickle cell disease, followed at St. Jude Children's Research Hospital in Memphis, Tennessee. And we wanted to look at low bone density and how it associates with AVN and pain in this patient population. And so what we did was through different analyses, we showed that if you have low bone density, like we measure it on a bone density scanner or a DEXA scanner, if you have low bone density, you have a 4 times higher risk of having hip AVN. You also have a tenfold higher risk of having chronic pain. And the way that we define chronic pain, it wasn't a perfect definition, but for the purposes of this study, we define chronic pain as anybody with sickle cell disease who also needs to be on opioids for pain relief for at least continuously for at least 6 months. So it's a very broad definition. The real definition, or the more accepted definition, is actually a shorter period, about 3 months or so, and you don't necessarily have to take opioids every single day. So our definition was actually a little bit more stringent. But regardless, we showed that just having low bone density by itself, after correcting for a whole host of other factors, does, we think, significantly associate or increase your risk for hip AVN and chronic pain. So that was in a pediatric population, so children, school-age children, and adolescents, ages 6 to 18. So I was very curious about looking at the same question in adults with sickle cell disease. Once again, because I primarily take care of adults, I wanted to see if we could see the same association. I felt like we should see the same association, and I wanted to see if I could better understand why it was happening, and also that question, like which comes first, the chicken and the egg. We know that people with AVN, mostly it's in the hips. Most adults, if they're going to have AVN, it's in the hips, but it can be in the shoulders. It can even be in the knees, any sort of weight-bearing joint. I've not seen it in the ankles, but I'm pretty sure it can happen there too. We know that there's a strong association between AVN and pain, but how does low bone density, signified here by low BMD, how does that associate? Is it making it worse, or is it existing first before either complication? It's a term that we call a confounder. We don't know really how it associates. Where does it fit into this mix? So the first study that we did was the bone pain study, the sickle cell disease bone pain study. And I'll just walk you through the schema on the left. We recruited a cohort of 53 adults totally. In total, we were aiming for 50, we got 53. And what we did was we did a bone density scan, or a DEXA scan, on all of the adults in this study in real time. We just obtained one study. And we also did something called a VFA. It's just simply an X-ray of the spine to look to see if there are fractures in the spine, which is also an under-recognized skeletal complication of sickle cell disease. We wanted to measure their bone density. We also asked all patients, all people enrolled in the study, to fill out a pain survey, a validated pain survey that is a way of assessing sort of the burden of pain, or the impact of pain over, like, a 7-day period, as a way to try to get to who is struggling with chronic pain and not. And then we also wanted to measure the extent and the amount of vertebral fractures that we saw. So sorry, the slide is a little bit, this is a little bit of a busy slide, but I'll just walk you through it. This is just breaking down the characteristics of the patients that we enrolled in the study. Overall, we enrolled 53 patients. Most were SS, and then the next majority were SC. We had about 45% of people, so 24 of the 53, were on chronic opioids. They had been taking opioids continuously for at least 3 months in the year prior, 3 months continuously in the year prior to enrolling in the study. And about 42% of them also had AVN, or osteonecrosis, as it's more technically called. I was really interested in, once again, looking at whether or not having uh, low bone density in and of itself would associate with pain, or if whether or not if you had low bone density and AVN, that would be more pain. So I'm going to walk you through this. These are all, every circle that you see is an individual that was enrolled in the study. And then in the red, that's the category for people who also have AVN. They could have AVN in one or both hips, in one or both shoulders, or all of the above. People in blue do not have AVN. At least they don't have AVN that we had picked up by imaging. Everybody else in the red, we had actually defined that they had AVN on either an X-ray or an MRI of the affected joint. Now, the open circles are people that were not taking opioids chronically. The filled black circles are people that are taking opioids chronically, basically almost every day. And so what you'll see when you look on the left side is for people who had normal bone density, so they did not have any evidence of bone loss on the DEXA scan. The pain scores, these are the scores that patients reported themselves. 50 is considered the mean or the average of pain in people with sickle cell disease. And this was from a much bigger study across the United States, so we think it's generalizable. So for people, if you're scoring at 50, that's about the average of what an adult with sickle cell disease would report as their pain impact, or how pain impacts their daily activity. If you are below 50, that means you have worse pain, or the pain is impacting you worse. If you're above 50, it's better. So within the individuals with normal bone density, here on the left, the pain scores were very similar. Those with or without AVN or osteonecrosis reported similar pain scores. There was no, it wasn't significantly different. Even, and then roughly about the same amount of people where more people with AVN were using opioids. That's not surprising, right? Because AVN is very painful. And then if you didn't have AVN, far fewer were on chronic opioids. Interestingly, when we look on the low bone density side of things, the difference is very significant, right? You can see that if you have low bone density and AVN depicted here on in this middle box plot in the red, your pain scores were very low compared to the median. And everybody, even though this number was small, all 5 of them were on chronic opioids. If you had low bone density without AVN depicted in the blue, about 50% of people were on opioids, but their pain scores were similar to the previous group. So something inherent about low bone density and AVN is associated with worse pain. And we suspect it's probably, even after we adjusted for the whether people were SS versus SC, whether or not they had different levels of hemoglobin or sickle hemoglobin and all of those things as a way to adjust for severity, there was a significant difference. So in summary, in the bone pain study, what we found was having AVN and low bone density associated with worse pain. And then the other things were if you had a lower hemoglobin, a higher indirect bilirubin, or a higher white blood cell count. So roughly, just markers of more disease severity, you are more likely to have low bone density. So that was our primary take-home point from that study. The next study that we did in our group was to look at a subset of those patients from the previous study that I just presented, and as a way to try to understand why they have some of these skeletal complications, whether or not people always posit, or they always hypothesize that, sickle cell disease is affecting blood flow to the tiny blood vessels, and these tiny blood vessels feed the bone. And if these blood vessels are compromised, or if the blood is not getting to the bone, you see a lot of bone death or bone complications. So we worked with our nuclear medicine colleagues here at UC Davis. We have a very novel way of imaging, or a very new way of imaging how blood flows in real time to the bone. So it's a cohort of patients. We were aiming for about 16 patients. We got 22 total. We gave them an injection into the vein, and this injection included a tiny radio tracer that hones to the bone, so it goes to where bone is actively dividing. And we did a total body PET CT, which I'll show you in the next slide. And then we measured, in addition to labs, we measured their pain impact and other important questions about, sleep and functionality and all that. We did a physical exam. We had patients do a functional assessment to assess bone strength in the upper extremities and the lower extremity. And this is a cartoon of what the PET CT is. So for those of you who have undergone a CT scan, which will be many people, this is very similar to what you do. You're just measuring a certain area of the body. It could be your chest, your abdomen, your pelvis, you name it, your brain even. A total body PET CT is novel because you can measure everything. You can measure the entire body at the same time at a fraction of the time that it would take for a standard PET CT. And the reason why that is important is you're measuring, in our case, we wanted to measure how blood flows to the bone at a single time. I mean, the study takes it took about an hour, a little over an hour for the first one, about 75 minutes to measure how blood flows in. And then we re-measure the patients again about 2 hours later to measure how much of that is incorporated into bone flow. So here are some images from the study. This is one of the patients who was enrolled in our study. This is a 33-year-old woman with S beta plus sickle cell, which on paper should be a mild form of sickle cell disease, but she had had a lot of complications. And so what I wanted to walk you through is how you interpret this. Sodium fluoride, or NAF, is the radio tracer. The areas where you have a lot of bone turnover are more like white or orange. You can think about that as being hot. That means it's taking up a lot of the radio tracer because there's a lot of bone breakdown, a lot of bone formation. The areas that are kind of like in the green or black are not avid. So these are areas where the bone turnover is quiet. There's not a lot of bone turnover. And then the blues and purples are kind of in the middle. So you can see in this young woman, she had had surgery about a year ago where she had to have pretty extensive lung surgery. So you can see over her sternum, or the area in the middle part, there's a lot of bone turnover. There's a lot, it's a kind of like white hot right there, where it's showing where she's healing from her previous surgery. And then what's very interesting is, as adults, we really shouldn't be, remember the slides I showed you in the very beginning? We kind of hit our peak bone mass in our 20s, and then we hit a plateau, and then it should start to decline. We really shouldn't be having a lot of bone turnover in our 30s. But as somebody with sickle cell disease, because of how sickle cell affects the bones, you can see throughout her skull, throughout her spine, basically throughout everywhere that we're measuring right here, there is active bone turnover. There's a lot of orange, some white, and then you can see some purples. So that just correlates with areas where there's significant bone turnover. When we look at the same patient at her lower extremities, you can see over her pelvic region, which is where a lot of us as adults concentrate our bone marrow. There's a significant amount of bone turnover as well. In the heads of her femur, there's some bone turnover. And then what was really interesting to my radiology colleagues is when you look closely, like in this middle portion, they put the arrows in there. You can see areas where the bone is quiet, there's no uptake of the dye, and then inside of the bone, a phenomenon called bone within bone, you can see that she's trying to form bone inside the long shaft of her femur, which suggests that maybe there was a previous injury there, maybe a bone infarct from her sickle cell disease. And even though she's an adult, she's still trying to lay down new bone, which, I think explains a lot of the abnormalities that we see on imaging in people with sickle cell disease. Similarly, when we look at the femur, this is a shot. I'm just focusing on the ones in the middle because it shows the colors more clearly, but this is the same image on CT and PET CT, and then the middle is fused. You can see a lot of areas of bone turnover. And then in the head of the femur and in the trochanter, like the sort of pointy part of the femur, there's not a lot of bone turnover. So that suggests that that might be some AVN in that region. So moving on, we were thinking about, what other alternatives can we adapt from the non-sickle cell patient population, where they also have significant bone loss. For instance, people with osteoporosis, people with other sort of other complications that affect the skeleton. So bisphosphonates are medications that are used in people with severe osteoporosis or severe bone loss to strengthen their bones and help them actually slow down the degradation or the destruction of bone. Not destruction, that's not the right word, but it's to slow down the breakdown of bone just to give your body a little bit of time to balance out the bone. We think of bone, it's not a static organ. It's constantly being turned over. So we think of bone, especially in younger children as they're growing, and then even more so in adolescents when they hit their growth spurt, there's a lot of active bone turnover. So um, in some colleagues of mine in Canada looked at children and adolescents with sickle cell disease and significant bone complications, and they try to actually treat them with a medication called Zometa that's a part of this category called bisphosphonates for bone strength, basically. So this is a bone biopsy. This is like the gold standard of assessing bone health. So it's almost like taking just a tiny amount of the bone and looking under the microscope. So in this 16-year-old boy with sickle cell disease who had significant bone pain, a lot of AVN, and severe low bone density, they did a bone biopsy, a transiliac bone biopsy. Normally, the inner part of the bone should kind of look like I don't want to say, well, it should look like a Tetris, there should be some sort of form or structure to it. And you can see on this image to the left that it's more disorganized, more amorphous. It's kind of like everything is kind of not, there's no structure. You can't really see, you can't appreciate the structure. And on the outer part, what we call the cortex, or the outer part of the bone, it's hard to see. But when they measured it, as you can see the measurements down here, they compared it with a reference of other children of his age, other boys of his age, and they found that um, his cortex was about less than 50% of what was expected, and the bone in the middle, the trabeculae, was about 3 times more distorted than expected. This young man was treated with bisphosphonates for about 2 years, and they repeated a bone biopsy on him. And you now can see that architecture is better in the same area, and his cortex has improved. It didn't quite normalize, but it has improved, and he has significantly less bone turnover. So one of my mentees and I wrote this up. We wrote up about, our experience treating younger people with significant bone pain from sickle cell, where we couldn't really pinpoint what was causing the pain. We wrote up about our experience in treating, at this point, I think we've overseen about 4 or 5 people receiving Zometa for bone pain and sickle cell disease. And so I put the citation here. But basically, what we think is going on is that the bisphosphonates are either regulating the aggressive bone turnover that's happening in people with sickle cell disease because of their underlying sickle cell disease. And it's also, it's sort of improving pain by reducing the sort of when there's a lot of bone turnover, there's a lot of cells that are recruited to that area that we think are activating pain sensing fibers in people with sickle cell disease. At least that's what we think is happening when we look at mouse studies. And so we're still doing ongoing work to better understand why this class of drugs might be beneficial in people with sickle cell disease. So the last study that we are opening here, the most recent study that we just opened here at UC Davis is looking at adults, so all adults, instead of doing Zometa, which is an IV bisphosphonate, we're doing alendronate, which is an oral bisphosphonate, treating people over 6 months, measuring their pain scores and other markers of functionality, collecting blood and urine, and also doing a PET CT before they get the alendronate and after they get the alendronate, so we can better understand why first of all, understand if this medication is helpful and why. How is it helping? Is it helping because it's reducing these bone turnover markers, or is it helping because we have improved blood flow when when you're treated with these medications. So, in summary, low bone density is very common. We think that it can actually worsen pain in people with AVN related to their sickle cell disease. We've demonstrated that a PET CT, a total body PET CT with the bone tracer is a very good way to measure blood flow and turnover in sickle cell disease. And our most recent study, we are trying to answer in a bigger population what the role of bisphosphonates are in strengthening bone and hopefully reducing pain in our patients. So thank you so much for your attention. I think I went a little over 20 minutes, but thank you for your attention. I'm happy to take questions. Let me get rid of this slideshow. Okay.
Awesome, awesome. Lots of information. Do folks have questions?
That was interesting, and I was really interested to hear about how bone and and blood are intertwined. Um, as I am one of the older sickle cell people, um, and I've started to have more bone pain,
Hmm.
this has been more interesting to me. Um, so thank you for bringing this forward and uh, a lot of things to think about and
Hmm.
keep track of as far as continuing studies and and are there going to be studies for people that are over, say, 50?
Oh, absolutely. So in our study, both studies actually, our age range was 20 to 67. So our oldest patients, actually, we had four patients above 60, sorry, above 50 that we included in the study. So our hope is that, we can, once again, I primarily see adults, and so my population skews older anyway. So
Mhm.
yeah, because I know that the interplay between aging and sickle cell obviously is significant. And so yeah, we don't, there's no upper age limit for these studies that we're conducting. Our oldest patient was 68 and she's now 70. And so yeah, we're hoping that she'll participate in this study too.
Yeah, it's really interesting because for me anyway, I had both hips replaced when I was 30, and now I'm 60 plus, and now of course, other joints are being affected. And
That's
it's
right.
like, well, in the interim between 30 and 60, are there things that can be done that will help with the bone density
Yeah,
and things of that nature?
I agree 100% because I spent a lot of time thinking about this. I'm like, yes, we see this in sickle cell, but we see it in other populations too. And these other populations with osteoporosis are getting treated. Why can't we extrapolate that? Obviously we have to do it safely and mindfully and initially make sure that there are no complications, but we should be able to extrapolate and not just say, oh, it's your sickle cell, deal with it. Actually can strengthen the bones. There are things that we can do to try to optimize the bone so that, yes, even if sickle cell affects the bone from a whole variety of other ways, we can try to mitigate that with, bisphosphonates or other medications that are known to improve bone health. And so, yeah, my whole goal was, not trying to reinvent the wheel, but if something has worked in other patient populations, we shouldn't say people with sickle cell disease should not benefit from that. They should. They should, right? Because we all know that these complications happen. Once again, my study in patients as young as 20, the study in Canada, they were seeing these changes in children as young as 2. So there's no reason why we should wait until somebody has to have their hip replaced before we start thinking, oh, maybe we should maybe make your bones, if we can, make your bones stronger. Yeah, that was one of the things that kind of like spurred me on in this field of research. There wasn't anything on it before, to the best of my knowledge. And so I do hope like it's just something to add to the armamentarium of making sure that, our patients can age and age well without significant mobility or disability issues as best as we can.
Thank you.
You're welcome.
Go ahead, John.
Thanks, Dr. Lucina.
Hi, John.
Hi, great to see you
Good
again.
to see you too.
How you doing?
I'm good. Thank you for asking.
Good. Thanks for the presentation. And I'm just kind of like curious, maybe I might have missed this in the middle of the presentation, but like, what are we doing to kind of like let young people know that they are at risk of bone degeneration? And then how can they ask those questions? Like, definitely, how can we ask those questions to our providers, first of all? And then the
Mm,
other part is like the correlation between like infertility and then bone density. That's another thing. Like most of us,
mm,
an area because we thought also only affects, a lot of that we didn't know it can also lead, bone effects like fertility issues, right? It can affect fertility issues.
that's
So
a good question.
I'm just kind of
Yeah.
curious, like,
Yeah,
huh?
that's a very good question. That's a very good question about, how do we just even bring awareness about this. I talk about it all the time in clinic, but that's because it's a big area of interest for me. But when we look at the guidelines, it's a little bit outdated now, but when we look at the guidelines published about overall health in sickle cell disease, it's dated. It's like 2014. A new one is supposed to come out in 2024. I don't know what happened, but they barely talk about the bones. And I looked at that guidelines and they're just like, oh, just do whatever you would do for the general population. In the general population, they don't screen for bone disease. They don't screen for bone density issues until they're 50 or older, until you have menopause. And that does not apply to sickle cell because we see these bone changes in young children. So I'm hoping that just putting the work that my group and I do, just putting that work out there will increase awareness. But you're right, there are other things that we can be doing. Maybe like talking in forums like this, sharing this information with the community through different social media platforms. Also, just trying to put awareness in there so that they can change the guidelines or modify the guidelines to say we should actually screen for this. Another question that I often get is um, if you find these skeletal issues, there's nothing you can do, which I push back against. That's not true. A lot of times, and I see this all the time, where they're like, "Oh, it's your sickle cell. There's nothing you can do about it." I actually think that that's not true. I think that's kind of like a fatalistic attitude. I do think that it's important to think about, just think outside the box, right? It's not. For me at least, it's not like I'm sure there are many things that we don't have a lot of solutions for, but bone loss is not one of them, right? Because it's a very common complication in other disease states. With regards to your question about fertility and bone health, um, to the best of my knowledge, there's not a direct correlation. The only thing that I can think about is in people who have either sickle cell disease or thalassemia, where they've received a lot of transfusions and over time develop iron overload. Iron overload can impact fertility. Iron overload can also significantly impact bone health. And so that's the association that I'm aware of. Another way to think about it is if your sickle cell disease is very severe to the point where it's causing a lot of other organ damage, the bone is essentially the biggest organ in the body. So your bones will not be spared if you have very active or aggressive sickle cell disease. And so another one of the studies that we're working on here is to try to see because oftentimes the downside is we're not picking up these issues until people have symptoms. And by the time you have symptoms, it's irreversible. And so one of the studies that I'm writing up now is people with sickle cell disease get scans all the time. You're getting a chest x-ray for this, you're getting a CT scan for that. All of these things, you're picking up bone, like you can't exclude the bone from it. And so if we can actually, I'm working with one of the radiology people here, if we can actually pick up some of these early changes in the bone when we're just scanning for other things, can we intervene and potentially either delay the onset of these skeletal complications are prevented altogether by either more aggressive sickle cell management, or maybe even instituting some of these bone-directed therapies. So you are right. We need to do a better job, and I think that's one of the things that we struggle with in academics. We do all these studies, but to get it out to the community and to make sure that it's in a way that is easy to understand and easy to act upon and can actually change the management that we do, we're kind of lacking in that. But yeah, no, it's a very important question.
Also, what about physical activity and bone health? Is there some causation there?
Yeah, that's a great question. So in the past, I think I was guilty of this too. I would say like, hey, if you're having a lot of pain, rest, use heat, don't overexert yourself, that kind of thing. But others have shown that a moderate level of physical activity, walking, if you have access to a pool, swimming, things that aren't going to cause a lot of high impact and potential injury to the joints, but moderate impact, moderate level of physical activity, or as well as your body can tolerate, it's actually critical and important for bone health because the muscle and the bones are interconnected. They are essentially a dual unit. So you cannot build strong bones if you don't have adequate muscle mass. Part of my research also looks at muscle mass and fat mass in people with sickle cell disease. And so, without adequate muscle mass, which you can only develop from exercise, physical activity, without adequate muscle mass, you can't really strengthen the bones. And so now I recommend, as much as patients can tolerate, as much as they can adapt to do some level of moderate physical activity. It actually helps. It's better. It's better for chronic pain. Now, I know that sometimes a lot of people are limited because of severe AVN, but my hope is that even before the AVN gets to the point where it's debilitating, we can try to implement moderate physical activity, things that maybe are not as difficult on the joints. But, I know that it's also somewhat of an access issue for some people. We've tried here at my institution to like recommend actual monitored cardiovascular exercise for some of our patients to some degree of success. Sometimes we don't have any luck with insurance covering it. But yeah, there are some facilities in different areas within Sacramento where you can actually go in and do aerobics, go in and do pool exercises in a way that's safe and monitored. Um, but it's variable when we can get insurance to cover that or not. But yeah, we do try, even if it's walking, 20, 30 minutes a day, and it doesn't all have to be at once, but some level of physical activity is critical and important to sustain your muscle mass and improve your bone mass in the process.
Oh, thank you for that. I was
Mm.
thinking about, having more physical activity when you're, between ages 20 to 30, which could, of course, stave off some of the AVN that you
I
get.
agree. I used to think that too. I used to think, oh, if you have AVN, don't walk. That's what we used to do back in the day. We'd say like, don't walk, limit weight bearing, use a motorized scooter, that kind of thing. But it's actually not, if anything, it's a little bit counterintuitive to actually do some walking. Even if you need an assisted device, do some walking because it's not just the bones that are impacted in AVN, the ligaments, the tendons, they're all interconnected. So if you can strengthen the muscle, strengthen the tendons, the ligaments, it actually alleviates, kind of counterintuitive, it alleviates some of that AVN pain and stiffness, and improves range of motion, and can reduce pain in the long run. But it does take time. But yeah, that's absolutely right. I do think, prevention is is always better than cure, So yeah, I'm hoping we can change the conversation around that. Moderate physical activity is actually good.
Thank you. Go ahead,
Mm.
John.
I have one question.
Yes.
Well, Tim, is there anything we could take, like over-the-counter supplements that can help like slow some of this down. Um,
Yeah, it's a very good
see stuff
question.
like I don't know, collagen and calcium. But I'm just kind of curious, like
Yeah,
what
yeah,
can
that's a great question. That's a great question. So what we often say, and once again, we're extrapolating this from the general population, but I think it also would apply to sickle cell. I think a lot of people um, they've studied this up the wazoo, vitamin D deficient, for a variety of reasons. It could be that, anybody really of African ancestry has a difficult time with dairy, and that's the sort of biggest source of uh, at least biggest food source of vitamin D. So optimizing your vitamin D, you can take a supplement over the counter. We always check. Part of my sickle cell labs that I check basically in everyone that I'm meeting for the first time is their vitamin D levels. And so their vitamin D is low, which is very common in people with sickle cell disease. Also, with darker skin, it's harder to absorb. It's harder to absorb the exact band of sunlight that you need to activate the vitamin D in your blood. So I always recommend, vitamin D supplements. Um, Calcium is also important. The medications I talked about, the Zometa, alendronate, those medicines, they're not, they cannot work on their own. You actually need the building blocks of calcium and vitamin D to be able to have them optimize bone health. So over the counter, I would say yes, calcium, possibly definitely vitamin D, possibly calcium. I don't think there's any harm in trying. You'll see these everywhere, Costco, CVS, you'll see them everywhere, like these collagen peptides. I don't think there's any harm. I do know that a lot of people with sickle cell disease have impaired muscle mass. That is true. And I don't know if it's because people are not as physically active. Because of other issues, either, AVN or other issues, or it's limited in the diet. But yeah, I do think considering supplements in that regard is possible, but definitely have a conversation with either your primary care or your sickle cell doc about, hey, let me just make sure, am I vitamin D? Is my vitamin D okay? What do you think about, measuring my bone density? Through the bone density scanner, you can measure the person's muscle mass and their fat mass and, make adjustments that way. So some of the things that we're doing in the study as well, all those patients that enrolled in the study, we're also assessing their muscle mass, their fat mass, and trying to see if we can see a correlation between that and some of the, pain scores that we measured. So, yeah, no, thank you, John. You bring up a very good point. I do think, once again, we don't have to invent something new. We can just pinpoint, hey, this is a problem, this is lacking in our patient population, and what are others doing about it, and how can we adapt that for people living with sickle cell disease?
I have a question also, as you talked about the collagen and stuff like that. And sometimes, I mean, we can be able to get these things over the counter. And you mentioned that we can talk to our doctors to figure out if it's okay, if they can measure density and stuff. So something like collagen, is it something that they'll be able to determine the dosage based
That's a
off
good
of the bone
question.
density, or because vitamin D is easy to
Yeah.
measure, right?
Yeah,
But
vitamin D is easy to measure. Yeah, that's a very good question. So, to the best of my knowledge, no, I don't know of a way of, yes, on the bone density. This might be because I think about this all the time research-wise, but on the bone density scanner, you can measure the person's you can do it's just a simple whole body. It's just basically a simple X-ray, and they can actually in the machine it spits out the person's lean mass, which is actually just their muscle. It also spits out their bone, and it spits out what's fat. So there's a way for us to measure it, and then it tells you relative to people your age, gender, and race ethnicity, how are you different? So in our study, we measured all of these in our adults. Now, we can say, yes, your lean mass is low, but I don't know, and I'm not aware, I'm sure there's probably ways, what is the dose of collagen or, other sources of protein that you need to try to optimize your muscle mass? That I don't know. But I think it's a standard dose for, at least on those supplements, it's a standard dose. To the best of my knowledge, I don't think there's a prescription for collagen, so to speak. It would just be whatever is recommended on the dose, I mean on the package. But I'm not aware, actually, that's a good question. I'm not aware of any studies where they've looked at collagen supplements in people with sickle cell disease and measured like pre and post.
Yeah, I'm doing this 11. So I'm trying to supplement as everything that I hear, I try to supplement. So nice to hear about the collagen part because I've never heard about that.
Yeah. Yeah, I use collagen supplements too. I think the older you get, the harder it is
Yeah.
to make sure that your diet is rich
I
in
use them. I don't want to
proteins.
be old.
Yeah.
Uh, I have a quick
Oh, wait,
question.
so
I'm sorry.
oh, no worries. And then after Peggy, Jean, I see that you have your hand raised, so we'll go to you next after that. Go ahead, Peggy.
So is bone deterioration or AVN, is that prevalent in those with sickle beta thalassemia as well?
Very good question. So, yes, well, how should I answer this? In our study, and one again, this is one study of only 53 adults, and there are other studies too, it was more prevalent in people with SS beta 0.
Mhm.
So I think it was roughly, let me see if I have the number up here. It's more prevalent in people with SSS beta 0. Once again, I don't know if it's what we call confounding by like disease severity. So in those with SSS beta 0, it was about let's see, about basically 80% of them. So in the subset of the 53, those with SSS beta 0 were the majority, and of those, 80% of them had low bone density. In those with SC and S beta plus, it was a much smaller percentage, about, let's see, what do I have here? Only about 10%. So in our study, we definitely saw a stark contrast between the those with SSS beta 0 and those with SCS beta plus in prevalence of low bone density. And it was a similar thing to the pediatric study we did a few years ago, several years ago, where it seemed to be more prevalent in those with SSS beta 0. We don't know if it's because having SSS beta 0 means you have sort of a more severe manifestation of sickle cell disease, and that's what we're seeing with the bones, or if inherently having SSS beta 0 just means that your bones will be more, I guess it's kind of a chicken and an egg. It's hard to know which one predisposes to what, but we definitely see that there's a stronger association if you have SSS beta 0.
Well, yeah, with that, John, you asked the questions you asked, I had in my head, so I appreciate you asking those because I had somebody, my granddaughter, but she she thought she had AVN. They thought she had AVN. She's pretty young, and she came over and she was so frustrated. And she said, "Why don't they tell you this? Why don't they tell you how to prevent this? I'm too young to have this." So, yeah, so when we think about prevention, the vitamin D, the calcium, I mean, what can we tell the young people to help prevent this happening, you know?
Yeah, that's a really good
Yeah.
question. Yeah, I also fully agree in prevention. I also
Mhm.
fully agree with finding ways to detect early before people have irreversible disease. I think it's really critical and important. A lot of people are like, oh, but there's nothing you can do about it, which I said before, I think is not, I don't think that's correct. Um, our studies, other people's studies have shown that you can potentially not necessarily reverse the AVN, but you can maybe slow down its progression. And then I know that there are ways, and maybe in the AI generation, this will be more accessible to us, but there are things that we know that can predict. Or there are things that we need to know that can predict, hey, this person has all these issues. They might be at higher risk for AVN. We need to try to aggressively manage these problems so they don't develop AVN. I don't think, because when you have AVN, the horse is out of the barn, so to speak, right? Like it's happened, it's damaged your bones. It's very hard to reverse it. That's why I think preventing it is really critical and important.
Thank you. Yes.
You're welcome.
Hello.
Hi.
Right. Well, I'm one of the older generations. I'm going to be almost 74.
Oh,
And
wow.
I do have the Beta Plus. And with the AVN, have had a hip replacement, is in my other hip, is going on my shoulders, is in my back. And I was fortunate not to have as many vaso-occlusal crises, but what, as Peggy was saying with her granddaughter, what they overlook is these things are still going on inside your body.
Yes,
And
yes,
so with the lower hemoglobin, that's still affecting the bone.
yes.
So I think you can't go by, you have to look at, okay, this one's maybe acting more severe, but internally the same thing is happening. And so
I couldn't agree with
just
you
keeping
more.
that in mind, because I was surprised all of a sudden, when it's just like throughout my body, you know.
Yeah.
Um, and so it caught me off guard because things weren't really said anything about it before, until the chronic pain hit, and okay, they did it, and it's here, it's there, it's there, it's all over. So
Um,
I think in that prevention is not to, keep in mind that, well, this is more severe, so they're going to be more affected, because that's not the case throughout. But
I
it's
agree.
so important to have that blood flow going through your system to keep that bone nourished. And if you're at a deficit, your whole life is going to affect the bone no matter what else is happening.
I
So,
fully agree with you 100%. We make the error, I don't know. We make the error of saying, oh, this person has severe, this person doesn't have severe based on the frequency or the frequency of crises or how often they're admitted. But we overlook a lot of things. I often tell myself, hey, sickle cell disease is sometimes like a silent disease, right? Sometimes people aren't in the hospital all the time. Sometimes they're not having crisis all the time, but the sickle cell is always in the background and it's always affecting the organs. And a
yeah,
colleague told me, and I always think about this, it's not just a blood disease, it's a disease of where the blood goes. So
exactly.
even if somebody isn't in the hospital all the time or having crisis all the time, they still have their organs are still being affected. And if we don't look for these issues and we just say, "Oh, you're doing great. You don't have any problems. You're doing great." I actually think we're doing a disservice to our patients. And that's why I'm hoping that my work and others will change the conversation about let's screen for these complications, let's detect them early, and let's treat them so that our patients, as they get older, the quality of life is preserved, you know? So, yeah, I definitely think we in the healthcare community sometimes do a disservice by just saying, oh, if you're not having crisis, then it's not bad and you're fine. Nothing for us to do. I don't think that's right.
And that's exactly my granddaughter. I mean, she's been in the hospital maybe twice. I mean, she hasn't, yeah, she doesn't experience that. So it was really caught her off guard. She's like, she's in her 20s.
Yeah.
And she says,
Yeah.
fortunately, it hadn't gotten there yet. So, once they did the MRI and everything, but there's things that we can think of, you should be taking more vitamin D, you should be doing this.
Yeah. We should look
Yeah,
for it. We should look
right,
for it and we should
right,
address it,
right,
not after the fact.
right.
Yeah. Thank
All
you. You
right.
Yeah,
brought
well,
really
thank
good
you.
questions.
Wow.
Sorry, I know we went way over.
No, 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 it's fine. I mean, it's information and education. I want to say to Dr. Edison, I mean, y'all know the story of Judah, and really, she was the one that really helped to pivot us when you said one day, look at his bones. And I'll never forget that because it really changed his trajectory for 6 years of pain. So I have been an advocate. I'm always asking her, can you come talk about the bones? Can you come talk about the bones? And even
I'm glad you did.
and I have told everyone I know, you got to get the bones, you got to look at this DEXA scan, which for us was not easy to get. I mean, they told
Yeah.
us no twice before we could even get it. And I heard
Mm.
it wasn't even an expensive test.
No, it's
But
very cheap. Yeah.
yeah. But to John's question, I know that we did at least go back to Odessa. We shared the story, and they were working on trying to preventively think about what would it look like to test every kiddo around 11 or 12 with the DEXA scan to just begin to measure bone density early. I want to say to you, Dr. Bimby, like you're doing your part by the research. And I think this is where community comes in to say, hey, then we can also remember we have power and voice. And it's really important that we're going back to our providers to say, not just for my child, but also for every child, like how do we make sure that no one else has to go through, for example, for us, it was like that no one else has to go through 6 years to figure this out, right? If we have this information, how do we make sure it gets to the next generation of folks? So I say that as we're ending, is we've learned a lot today. I want to encourage us all, pass it on, right? Talk to someone else who has sickle cell, talk to your family members, and educate your children about it if you're a caregiver. But also we got to go back to our providers and say, hey, we learned about this. How do we make sure that this gets out? And really, you have the commitment of at least the task force. We're going to push it out as much as we can through
I appreciate
newsletters,
that.
also the social media platforms. I love thinking about a campaign around supplements we should be taking in bone health. You said something at the end about that sickle cell is not just about the blood, but it's about everywhere the blood goes. That's a really,
It's
really,
really important.
yeah,
Yeah.
really great wisdom. And I think that's what I'm taking from today. Wow. Yeah,
Yeah,
absolutely.
that I heard. Yeah, that was really that impacted me a lot because yeah, like you say, a silent disease. Things are going on in your body that you're not even aware of sometimes until it's too late, you
Yeah.
know.
Yeah.
And it's yeah.
All right. With that, we are at time and we have had three wonderful guests today. Dr. Adesina, thank you so much for your time.
Thank you for
If
having
if
me.
folks have questions, do you mind if they reach out to you?
Oh,
If you
sure.
drop
Yeah.
your email in the
Yes. Oh,
chat?
I will.
If you have more questions, all the presenters today were listed in the chat if you want to talk with them. Again, thank you for our first of the year education series. We hope you enjoyed it. We learned a lot. And we hope that y'all have a wonderful rest of the day. Go Seahawks.
Go
I know some
Hawks.
folks got to get off because you got to go get ready for the game. But and then just to remember again, our next event is the Wellness Day on January 27th over at the Sickle Cell Hub. Again, sign up if you can. And then we have the gospel concert February 21st. We're always here, always available. Please check out our website. It has been redesigned and it has all our information up there. And
Looks great.
thanks. We will be posting all of the education we got today. So if you need to go back and look at this a little bit more, by next week, we hope to have them all on the YouTube page. All right.
Bye, everybody.
Thank
Thank
you
you for having
so
me.
much. Thank you. Thank you. This
Bye.
was very, very helpful. Thank you.
You're welcome.
Thank you,
Bye.
Hi,
everyone.
Charity.
Hi, Foxy. I'll be reaching out to you sometime.
Sounds
I think I
sounds great.
called you. I think I called you, but I wasn't. I don't know if you noticed that I called you last week.